Hello, everyone, and welcome to our ISCN 2024 update series. Today, we're going to speak about neoplasia-specific changes and a reminder that next month, there'll be optical genome mapping. For today's talk, we have again Dr. Ross Hastings, who is a state-registered clinical scientist and fellow of the Royal College of Pathologists. She has more than 35 years experience in constitutional, acquired, and molecular cytogenomics, both in a research and diagnostic setting in the UK. For the past 20 years, she was the director of an ISO accredited proficiency testing provider for cytogenomics and genomics. Dr. Hastings now works part-time as a cytogenomics consultant for GenQA, an ISO accredited PT provider operated by Oxford University Hospitals. Dr. Hastings is the chair of the ISCN Standards Committee since 2020, editor of ISCN 2020, and lead editor of ISCN 2024. Dr. Hastings has authored many publications and book chapters on genetics, NIPT, PGD, ISCN, and PT. In addition, she is an author on many best practice guidelines. And now I will turn it over to Dr. Hastings for her presentation on the 2024 updates. Just a reminder, if there's any questions, please place all questions in the Q&A. They will be answered at the end of the session. Thank you very much, and thank you, Dr. Hastings, for presenting.
Thank you, Celeste. I shall now share my document. Okay, so today we're going to talk about the neoplasia-specific ISCN. We're going to talk about the changes and additions to ISCN 2024. So if you're looking for understanding all the basics in neoplasia ISCN, it doesn't cover everything. Because we haven't changed a lot of the information on neoplasia ISCN. So just to say there's a potential conflict of interest because as a consultant for GenQA, which is a global PT provider, and the ISCN Standing Committee chair, somebody could consider this to be a conflict of interest, but the PT providers encourage the use of ISCN and also identify gaps in it. So personally, I don't think there's a conflict of interest, but I just put it out there in case some of you do think it is. So today I'm going to talk about the neoplasia ISCN. I'm going to talk a bit about composites because from a PT provider perspective, we found people misunderstand how to write composites, and we have put more examples in the book. I'm going to talk about clone order because we realized this was something missing in the rules when you get equal complexity of the clones in neoplasia, and a bit about targeted analysis using neoplasia examples. In the earlier talk, I used constitutional examples. And then with the help of G. McGowan Jordan, who was also the ISCN Standing Committee chair prior to me, we're going to answer some of the questions and do the quiz. So again, just to remind everybody about the history of ISCN, and that is that neoplasia didn't actually come into specifically identified in ISCN until 1991, which is rather late. And then things like IDEM and Sideland and subclones didn't come into 2009. In the latest version, we've revised the structure. We've put all the rules in the text, in a generic chapter in chapter 4, but also in the text of the individual chapters. And we've used Roman numerals to identify the individual examples. We've also included now targeted assays, both for chromosomes and arrays, which I'll discuss later. So we're going to talk about chapter 6, which is neoplasia. And you can see here that we have introduced a lot of over 50 new examples in the neoplasia and other chapters where relevant. So I mentioned at the last talk, there's some errors. We've identified another one. I picked it up last week where there's a space missing after nukish. And that's in 7.3.4.4.21. You will get a copy of these slides as a PDF, so you don't have to worry about making notes unless you particularly wish to. So just to go through some of the basic neoplasia ISCN rules, cell numbers are given for all neoplasia karyotypes and neoplasia fish. For constitutional, it's only done when it's mosaic. The normal sex chromosomes are always listed before an abnormal X or Y. Numerical, then structural aberrations are listed in chromosomal order. All abnormalities are described from Peter to Cuter. That was introduced in ISCN 2020. And the structural aberrations of a homologous chromosome are listed in alphabetical order, i.e. del 7 goes before inversions 7. So if you had this example, well, you had a numerical loss, then you had the other chromosome 5 had a structural change, then the numerical goes before the structural. In this particular case, you've got 2 structural, but del goes before the inversion. And then obviously, because we're doing numerical order, the +8 goes next, and the normal cell line always goes last. However, also remember, if you're talking about a derivative 7 on one chromosome 7 homolog, you describe that from Peter to Cuter. So in this case, you don't use the alphabetical rule because you're describing from Peter to Cuter of one chromosome. So the imp might go before the del. It's just to remember where the rules separate. And normal cells are always listed last, except for in nuke-ish. So when it comes to the order of the clones, then in neoplasia, when they've got the same complexity, we've introduced some sequentially applied rules, and they're both in chapters 4 and in 6. We've also given some figures for the divergent clonal evolution, unrelated clonal evolution, to help you sort of work out how you do this from scratch. Another question that came from participants in the PT programs was, what band resolution should we give, and is it adjusted to the gene location? Because in a lot of neoplasia, you've got recurrent structural aberrations or rearrangements. For instance, they say the 821 translocation. And what the ISCN committee agreed after much discussion was that you have to give the breakpoints according to the resolution you saw down the microscope or the resolution of the technique that you were using. So at 400 bands per haploid set, it'd be Q22, Q22. If, however, you're able to see it at 700 bands per haploid set, I mean, neoplasia tends to be poor quality bands, but occasionally you do get good ones and you can still see the abnormality, then you can put different breakpoints. And the reason for not giving the gene location is you cannot see it at that resolution, and therefore you might be possibly making an overinterpretation of your results. Another change has happened is that we put in ISCN 2020 how to count the chromosome aberrations to help people when they're trying to work out whether or not this is a complex karyotype or not, and it might help in the prognostic stratification. A ACLF French-based group had misinterpreted some of the rules that we put, so we've now put clarification by putting a separate table and explaining how that you do the counting. And we've put more composite karyotype examples in, and I'm going to discuss those in a few minutes. So the big change for neoplasia is the change in the fish rules. So now there is a space after the technique. So there's a space after nuke-ish, whereas before, if there's a bracket in ISCN 2020, there was no space. And the multiplication sign is always outside the brackets unless you've got different signal patterns. So it makes it consistent with the other technologies like RSA and array. So these on the left-hand side is what are correct according to ISCN 2020. And these are the changes, and the pink shows where there's a change. So here there's a space, which wasn't there before. The ×2 goes out of the brackets. Because these are different signal patterns, they stay within the bracket. And this would also apply to break apart and fusion genes. So again, you'd be a space here and the ×1 for the 3' IGH, con 5' IGH is outside the bracket. There are still spaces between con and either side of con and set. That hasn't changed. And the other big change is before, when you got a normal result, you could, we said you could mix all the probes together. But now we're saying that all results should be given according to their probe sets. So whereas an ISCN 2020 for a CLL probe set, where there are 2 hybridizations, one involving ATM and one involving ATM and TP53, and the other probe set involving chromosome 12 centromere and the 13q, this now has to be separated according to the probe sets. And because you've got 2 probe sets, there's a comma between the 2 probe sets. And don't forget to put the cell numbers in for each probe set. If you put it at the end, you don't know how many you've counted here. The other thing we've done is we've removed the detail system for all normal results, and this includes break apart and fusion probes, so you're only using what we would call now the short system. If you're getting confused when I'm talking about the short, abbreviated, and extended systems, please look at the first talk, because that's explained in more detail in the first talk. It's also in the book, of course. So now, this was in ISCN 2020, and you had this longer form, and it's now only the short form that is used. And that is because, sorry, I'm going too fast. This particular string, a lot of individuals were thinking this meant it was abnormal. And so we've now clarified that. So it is only the very short system that is used. So we're talking about composite karyotypes. There's been a lot of confusion about cell numbers, which ones you which metaphases you include, and the chromosome range. So the chromosome count that is given does not mean that all the metaphases have every clonal abnormality. I need to stress that at the beginning, and that's why I use CP, because that tells you it's a composite. This may be expressed by providing the number of metaphases in square brackets after each chromosome abnormality. So you can provide this either in this form here with a composite times 5, or you can say after each clonal abnormality, how many metaphases had that abnormality. So the del 16, for instance, is only clonal in 2 metaphases, these 2 here, whereas the -X is clonal in all 5 metaphases, and the +21 is clonal in 2 different metaphases. You do put the normal cells and you list them last, even if you only find 1 metaphase. Second point to remember is that the sum of the aberrations may indicate a higher or lower number than actually seen. So again, let's look at this slide. You've got clonally a +7, +9, +13, and a +11. The +21 and the +21 are not clonal, they're in single metaphases. If you write it out, you talk about the metaphases that have the clonal abnormalities. So the lowest one is 47, the highest one is 49. So it's 47 to 49, you use tilde. Then the sex chromosomes, and then you put the clonal abnormalities, and you put composite of 6. However, if you were to add that up, that actually makes 50. But you're talking about a chromosome range. And of course, they're not all present in every single metaphase. And again, you can individually put them here. So you can say there are 2 metaphases with 7, +7, 4 with +9, 2 with +11, and 2 with +13. And again, you still have to say it's a composite. Now, the chromosome range used in the composite includes only the metaphases with clonal abnormalities. So, in this particular case, these are the clonal abnormalities, -7, +8. The -20 is not clonal because you have to have 3 cells with loss of a chromosome before you can call it clonal. The first metaphase doesn't have any of the clonal abnormalities. So the chromosome count 42 is not included in the composite range. So you'll have it from 43, which is the lowest, through to 46. And then sex chromosomes -7 +8, composites of 4, but you can put them individually, how many metaphases had each of those clonal abnormalities. So hopefully that clarifies how composite karyotypes work. Now I'm going to move on to mosaicism and clones. I'm not going to talk much about mosaicism, but just so you're aware of the difference between constitutional and neoplasia. In constitutional mosaicism, when you're indicating a mixed cell population, the largest cell line goes first. For clones, in neoplasia, it's the least complex acquired clone that is listed first. However, you may, of course, get constitutional abnormalities and neoplastic abnormalities. And so we needed to say what the order was. It was in the book, but it wasn't actually specified. So we've now specified that in ISCN 2024. So hopefully that's clearer for everybody. So the abnormal clone, which is this one here, with the acquired abnormality is listed first. Cell lines with a constitutional abnormality are listed next, so the C after the +21. And then the normal cell, if it's present, is listed last, always last. So whether you're doing constitutional neoplasia, the normal cell line is always listed last. There's an exception in nukish, where the normal is in the denominator, except for in sex determination, when again it is listed last. And that's just an example of sex determination. So when we've got equal complexity of the clones, I shouldn't put cell lines there, but the clones, the following sequential order applies. And they've given examples for cell lines for unrelated and related neoplastic clones in chapter 4. And so you can find examples there when you want to work out what the rules are. And you apply these 5 rules sequentially. The first one you could argue isn't really a rule. It's just saying in post-transplant chimerism, the recipient is always listed first. And so the XY goes before XX because the recipient is male. When you've got abnormalities in different clones that involve chromosomes of a different number, the chromosome order rule applies, X before Y, followed by the autosomes in increasing number. So here's an example. Where you've got related clones, then the -5 is going to go before the -7. So that is listed first because they both got the 7-11 translocation. And we're talking about complexity here. And so it's not about cell numbers because we're talking about neoplasia. And in unrelated clones where you've got a +8 or a +21, then again, the 8 will go before the 21. If, however, when you've got equal complexity, the same chromosome is involved, then gains are listed before losses, before structural change. So if you look at a related neoplastic clone, then they've both got a T922. This has got a +19. This one has got a -19, so it's listed first. In unrelated clones, then the +5 is listed before the del5, and the normal cell line goes at the end. However, you may just have structural abnormalities of the same chromosome number, and then they're listed alphabetically. And so here you've got a del versus an iso, and the del, they've both got +8, but one's got a del7 and one's got an iso 7q, and the del7 is listed before the iso. And in this case, an unrelated, the ad7 is listed before the del7. So when you've got the same type of abnormality, which hopefully is the last type of difference you might have, going sequentially, going down, because hopefully the other rules will come into play before you come to this rule. When you get the same type of abnormality detected on the same chromosome, the P to the Q to rule applies. So in this particular example, the del 5, both got -7. Because that's an interstitial deletion, it's listed before the terminal deletion because that is much further down on the QTA. And in unrelated clones, then the Q1314 is listed before the Q14Q22. I hope that makes sense. So you can always go back to the book, or if you're not using the book, go online. Both of them are available. You can choose whether you just choose online only or you buy the book as well. And as I mentioned last week, the difference in price is because you've got access to the online version for 4 years as opposed to 1 year. So the other change we've introduced, which was really introduced because of neoplasia, is when you get a mixed clonal or cell population. And when you can't, because of the nature of the array or because of the nature of the sample, you cannot precisely quantify the mixed cell population. Now, some of these things aren't any changes, but some are. So you can put a range. So you can put 1 to 2. There's no change in that. That's exactly the same as ISCN 2020. But when you cannot determine the copy number at all, but you know it's not 2, then you can put times greater than 2 and then put query because you can't quantify it. So that's one possibility. There are in neoplastic samples, sometimes what you do get is you get a amplification, and then the platform, it's just too large an amplification to enumerate the copy number. And so therefore you use AMP. And again, because you can't specify to what extent it is amplified, you put AMP and then question mark. And you see here, you could actually work out that 80% of the sample had trisomy 8 and 80% of the sample had 2 extra copies of 22. The proportion, or the, if you like, the quantification of the copy number is not adjusted for tumor load. You're just saying this is what the DNA that I've got and this is what I am seeing. Another addition which applies to neoplastic samples is that when you've got multiple clones and they're not all at the same level, so some are at 50%, some are at 75%, some are at 100% of the sample, then it's optional whether or not you include 1. So in this particular example, you've got loss of the 13q13.1 region. And as I was saying before, if it is the same breakpoint that the loss is in, because you can tell from the nucleotides it's interstitial, you only mention the breakpoint once. However, when it spans 2 different breakpoints, you put both breakpoints in and the interval of the nucleotides. And again, this particular loss in 13q14.11, q14.3 is in 75% of the sample. And then the more terminal loss at 13q31.3, and again, you can see it is interstitial from the nucleotides, but this is ×1, and you could put 1 after it. It is optional whether you do or you don't, so you could write it like this. However, if the numbers were the different way around, such that the 13q13.1 was in 100% and the 13q14.11 q14.3 was in 50% of the sample, then you can see if you only put 0.5 at the end, somebody might misread this and think this applies to the whole string. And so, although it's optional, personally, I think for clarity, it is better to put 1 when you've got mixed populations with different percentage of the sample that has the abnormality. So if you've got a mixture here, I think it's still better to put 1 so people know you haven't forgotten and just missed off the actual level that it's actually 100%. And here, I certainly do think you should put it in there. But again, I'm only saying that because I'm just trying to stop people misreading the results. They can obviously read the text. Whether the clinician does is another issue. The other thing you can do in neoplasia, but not in constitutional, is that you can use the greater and lesser than n, 2n, 3n, so that you are using these symbols relative to the genome ploidy. So if we use this example here, we're saying there is loss of 1 copy of chromosome 5 relative to the tetraploid genome in 90% of the cells. And in a post-transplant sample, just to show that this is a percentage here, the male recipient after a transplantation with a female donor, and again, just remind you, the recipient is listed first. But in this particular case where you use these symbols, you can only use them in neoplasia. Now I'm going to go on to targeted analysis, which is probably going to be used more. It was asked for by the cytogenomics community. We've extended the the regional specific assay to include targeted chromosome analysis, both karyotype and array, fusion genes, methylation specific analysis, but that is more constitutional, and repeat expansion and contraction disorders. So the fusion gene nomenclature has changed. Before, we had pos and negative, and also for the normal, we had the 2 colons, which would imply an abnormality. And also pos and negative, it's all relative as what positive in relation to what. And so we took it all out, particularly as PT providers, we suggest not using the terms positive and negative, and yet the ISCN was doing so. This also came about as a consequence of a discussion with various other people dealing with fusion genes and what nomenclature should be used. And so this is the nomenclature that came out. Now, just to note, if you're doing normal, just like you do in fish, there's a comma between the 2 different loci, and ×2 goes outside. And it's following the numerical order rule that 9 goes before 22. However, when you're talking about an abnormal, depending which is the active oncogene, in this particular case, it's BCR-ABL, then BCR is listed first before ABL. So it's not following the numerical order rule, it's following the active oncogene fusion, that this is the fusion product, BCR-ABL1, not ABL1 BCR. So if it had been ABL1 BCR, then it would be the reverse way around. It'd be ABL1, 2 colons BCR, but that isn't actually the active oncogene fusion. The active oncogene fusion is BCR-ABL1. I hope I've not confused you by saying it, because there'll be 2 fusion events, and one is active and one often is not. And you basically are going to put the active oncogene fusion in place in the ISCN. So for targeted assays, you are, other than fish, you're going to use the acronym RSA, because you could argue that fish is a targeted assay. You only describe the normal and/or normal results for the specific chromosome region tested. And as I say, it now includes targeted chromosome analysis where a full chromosome analysis is not undertaken, and targeted microarray analysis where a specific chromosome or region has only been analyzed. So we are talking about numerical or structural aberrations. For a balanced structural chromosome complement where the homologous are currently normal, the abbreviated or short system can be used, which is analogous to full karyotyping. And the short system always includes the breakpoints. So if you're looking for the 821, this is normal, you can just put times 21, you've looked at 8 and 21. If, however, you've got a 922 present, then you would say there's 1 copy present and you put the breakpoints in. However, if the non-rearranged homolog is lost, then the short system is used and the number of the normal homologs is described as 0, because otherwise you don't know what you've got. Because if you don't put 0 here, you don't know whether or not you've got a normal 17 and an ISO 17, or you've only got an ISO 17. And so that's why you have to put 17 times 0. And here's a different one whereby you've got an 821, you've got one normal, you haven't got a normal 21, sorry, but you have got a normal 8. And when it's unbalanced, they're always described using the short system, where the normal chromosomes are also listed in the ISCN. So here's another one with the ISO 17, but you've got 3 copies of 17q effectively, and one where you've got 6,9, and you've got 2 normal copies of chromosome 9. And obviously cell numbers are given for neoplasia. And if you've got mosaics, it's the same thing, normals go last. And in the short abbreviated system, again, normals go last. You can see the difference here. This is the abnormal result, and this is the normal result. When it comes to array, in this particular instance, we're just saying we've got targeted analysis of the whole chromosome 17. In this, it's a targeted array analysis for the TP53 critical region on chromosome 17. If you've got loss of the region, depending which, you can use any of these 3 versions. This is the simplest of them, just basically saying you've got loss of that region. This is actually giving the nucleotide range, which is a short system. And this is the extended system, which talks about the normal flanking nucleotides around the loss of 17p13.3. So when it comes to sequencing, as I mentioned in the last talk, we've clarified the terminology, we've explained the examples for the different platforms and the bioinformatic algorithms. We've given more normal, aneuploid, mosaic, and complex examples. And we've said whether or not in the description you need to include both the ISCN and the HGVS, whether either could be used. You could either use ISCN or HGVS, or where the ISCN is more informative. And sequencing is exactly the same as arrays, whereas if you've got the same breakpoint loss or gain, it's only listed once because you can work it out from the nucleotides whether or not it's interstitial. There are more neoplasia examples. So we talked about a normal at the last talk, but I gave you a female. This is what a male would look like. If you've got an abnormal aneuploidy, again, because it indicates, you could argue it indicates the same information. I would say it probably doesn't indicate the same information, because with the ISCN line, you know what proportion of the sample is mosaic. So 60% has got 1 copy of chromosome 13. If you're using the HGVS, it's a much more lengthy description. And this means that basically you've got a normal chromosome 13. And this means that it is the other chromosome 13 is mosaic, because with HGVS, you are describing what you see compared to a standard. And that's why you have to write that you've got 1 normal 13 and that you've also got mosaic loss. So here's another mosaic result where you have got a 12-21 rearrangement. And this is where you would need to use both, because they give different information. And you can use this in the sequence nomenclature, although obviously it's cryptic if you use G-banding, and you couldn't use it. But in sequencing, you can use it. And then what you would describe here is you could describe chromosome 12, and then you'd describe chromosome 21 on a separate line. And so you know from this, you've got a translocation between chromosomes 12 and 21. You know from looking at the breakpoints that you've got you've also got a 1.68 kilobase deletion on chromosome 12, because these breakpoints, they tell you basically there is a deletion. And here, you know, you've got deletion on chromosome 22 at the translocation breakpoint as well, which is 600 base pairs. And as both the HGVS and the ISCN give you different information, both are needed. Now, having gone through all the changes, just like to reiterate that there are some educational resources for ISCN. I mentioned at the last talk, you've got the book, you've got the online version, you've also got the forum to ask questions, and we do go through them on a monthly basis. We sometimes go through them more regularly than that, but don't expect quick answers for diagnostic problems. If you do pick up errors in the ISCN, please use the forum to let us know, and we will get them changed online. There's a couple that still have to be done. There are several national and international PT providers that include ISCN in their assessment, so you will get your ISCN checked that way. Some, like GenQA, have a specific ISCN EQA, and the summary of all the changes is now available online. I sent the link last week to Celeste, and I can send it again if you've just joined this seminar for the first time, of a summary of all the changes. It is on a DOI number that you can have a look at it. We've also, through GenQA, got a new system called Genie, which is for individual competency, and it's modular and online, and can be used for ISCN and HGVS, and it's been updated for ISCN 2024. There are also webinars you can look at. The ASHG has got one about the changes from last year, although isn't the most recent one, and you have to pay to see it. There will be another one with complex examples coming later this year. There are some ISCN webinars on the GenQA YouTube, but again, many of these are for 2020. There is a recent one for 2024 and the changes, and obviously these talks will be available as a PDF. And there are workshops, but please go to GenQA and the CGC websites for more information about that. So the Genie is an online training and competency tool for individuals. You select the area of genomics where you want evidence of competency. There's more than just HGVS and ISCN. It's modular. It includes variants. There's a new one which is about working out which variants you should report and which ones you don't have to report, stratification of variants, and there's the nomenclature for HGVS and ISCN. As I say, it's individual, or you can buy it as centres. And there's a new trial for ISCN and HGVS, which is open. And there's 3 basic levels: basic, advanced, and complex. Basic is currently available free of charge. The advanced and complex will come later. And we've got it for fish, we've got it for karyotyping, and it will have array and other technologies later. And so you'll basically get an image, you get a description of what it is about, and then you select the correct nomenclature. And as I say, the Neoplasia karyotyping basic is free until the end of next month, and there will be more advanced complex scenarios coming out shortly. The fish will come out shortly, and then the others will follow suit. So at the end of this, you get a participation certificate telling you what you've actually passed. And then you will get a performance report, which will tell you whether you've got them all right. Little green ticks obviously show that you've got them right. Little red boxes with crosses in say whether you've got it wrong. And you get feedback explaining what it is you got wrong. Now, we know with all of these, there are multiple sometimes ways of writing the ISCN, but we've kept it strictly so there is only one correct answer for the scenario we've given you, in that the options you've got can only give you that one scenario. So you'll suddenly see another face coming up in a bit, which is Jean McGowan Jordan, who was the ISCN. She's still on the standing committee of ISCN, but she was also the previous chair of the committee. We're going to go through some quizzes, and then we've got questions at the end. So the first one, this is a female patient with a 3-way translocation, which is the correct ISCN for this result. I've just shown you where it all moves to, and there is an extra derivative 22 of the 3-way translocation. This example is in ISCN 2024. Oh, I can't see the boat. Ah, I can see the boats. Excellent. Oh, a lovely, lovely split vote. I do like that. That's really great. Okay. So by a small percentage, 35% of you thought it was A. And let's get this moving down. There we are. 38% thought it was B, which is the correct answer, and 27% thought it was C. So A is wrong because it's the lowest chromosome that is listed first, and then you follow where the chromosomes all move to each other. So it should always start with the 6. C is wrong because although it is a DIR22 and it only has chromosomes 9 and 22 in it, if you put DIR22, T922, it's implying there is a totally different rearrangement there, and you have to refer back to the original rearrangement, which is 6922. Second question. You've got interface fish result, abnormal result on IGH in 100 nuclei, a normal result in human in 100 nuclei. Which is the correct result? And this is a change from ISCN 2020.
I stopped the poll and shared the result.
Right, got the 70% of you got the right result. Well done. You're identifying ISCN 2024. B is partly right, but you need now in 2024 need a space after nukish. So you're nearly there. And that was 11% of you. And 90% of you put C, where you've got the space, brilliant. And you've used the ISCN 2020 with the ×1. This ×1 needs to be outside the bracket. So the next question is interphase fish. Got a normal result for ATM, centromere of 12, the 13 Q probes, and TP53 in 200 cells. Again, it's another change for ISCN 2024.
I shared the result.
Yes, got it. Thank you. Right. Let's move this on. Well done. 14% of you suggested it was A, which is, with the exception of having the space here, which is how you would write it in the ISCN 2020. This is the correct result, which 67% of you realise. Well done all. 13% suggested this, and this is the whole thing I mentioned about you need the cell numbers here It's an easy thing to miss, but don't forget to put the cell numbers for each probe set. And 5% of you thought it was here. It was a sneaky one, this, but there's a comma missing between the probe sets. So question 4, targeted chromosome analysis for only chromosome A. It's a mosaic non-disjunction trisomy in 8 out of 30 metaphases. This is probably very unfamiliar to you. Having said that, 61% of you got the correct answer. Well done, everybody. So 6% thought it was A. The denominator is used in nucleish, not in RSA. So just to be aware of that difference. 8% of you thought it was the second one, but the normal cell line is listed last, and that's a rule across the board. 25% of you thought it was this, but this is this is where the confusion is. This is targeted microarray ISCN. So you've got it right, but if it was a targeted microarray. However, this was a chromosome analysis, and this is the correct result, which 61% of you got correct. But well done, because it is difficult to get used to this. So I've given you a composite. I've also highlighted some of the chromosomes to make it easier for you. Right, what have we got here? Right, 4% of you chose this. You need to put the range of the chromosome counts with these chromosome abnormalities. I know that adds up to 46, but you need to look at the range, which is 43, sorry, through to 46. Oops. 15% of you put this one, but again, you only put the ones that you only include the chromosome count from the clonal abnormalities, and this has not got any of those clonal abnormalities, and so you can't put 42, it has to be 43. 68% of you correctly got the right answer, and 13% put this one in. Sorry to be, again, another tricky one, but the -20 isn't clonal because it's only 2 metaphases and it's loss that has to have 3 metaphases in it. Question 6. Can you put these 3 related clones in the correct order according to ISCN 2024? Right. So 10% of you thought this was the correct answer. It's just to remind you, gains before losses. I have to be honest with you, in ISCN 2020, we had two different rules opposing each other. One example had gains before losses and one had losses before gains. But we've clarified that now in ISCN 2024, and it is gains before losses. 85% of you, well done, everybody. That's high. Got the correct answer. 4% of you thought it was C. Normal cell lines always go last, just a reminder. And again, 1%, one person thought it was the normal cells went. D was right, but it's normal cells go last and it's gains before losses. So the vast majority of you got it right. Well done. And this is the last question. So can you put these unrelated clones in the correct order according to ISCN 2024? Oh, very good. So 89% of you got the correct answer. Very well done. 9% thought B was correct. Again, it's gain before loss before structural. So the numerical before the structural. Only two individuals, one each of these. Again, it's just a reminder, normal cells are always last. So overall, more than 2/3 of you getting correct. That's brilliant because you're getting used to the new ISCN 2024. And hopefully by doing this, many of you will remember the rules a bit more and be able to get the correct ISCN as well. So I want to thank everybody for being involved. We're going to do questions after this. That's the ISCN Standing Committee. The genomics community includes yourselves for the ISCN suggestions. Carga, obviously, who published the online ISCN and do the forum for us. Gen QA, obviously, for all that Genie information. And I prepared the slides, so I'm not going to thank myself. Any questions?
There are plenty of questions. Here we go.
Well, this is where Jean's going to come in.
So a couple of them are about
sharing.
About questions about the questions that you offered, and I'll send those separately to you. But the first one, in the 45XX minus 21 example given earlier, why did you assume that the patient has mosaic Down syndrome? For the non-mosaic Down syndrome, shouldn't it be 45XX minus 21 times 2?
Hang on.
I can take a stab at this. I think it presumes that you already know that the patient's a mosaic Downs. If you didn't, I think it would be minus 21. I guess you could put times 2, but I think you would put minus 21 minus 21.
Okay, here we go. For the RSA example of TP53 region, should the first option include both bands? So again, these are on slides. I apologize.
Yeah, I have to see the example that they're talking about because I think it depends on the technology and how big the...
Are we talking about? No, it doesn't, because should the first example, the normal, include both bands? They're different bands. So it does. Oh, are we talking about the abbreviated system?
Maybe it was the abbreviated system with the single.
Okay, but that's just saying we only looked at that particular region. So if you looked at both regions, yes, you put both bands in, but I'm just saying in that particular case, you're just looking at 17p13.3. So it depends what you're looking at.
Another question. Well, first a compliment. Thank you, Ross, for the great informative presentation. Going back to indicate the breakpoints based on the G banding resolution. I wonder if we perform FISH for the gene of interest, can we adjust the chromosome breakpoints according to the FISH result?
You can adjust it in the FISH.
Yes.
And you can, I think, in retrospect, actually, I think the rule says in retrospect, you can change the G banded. If you can see it, that's what it says. If you can see it in retrospect on the G banding, then you can change it. Otherwise, you can only change it in the FISH.
And then for the CLL example, how are the probe sets identified and separated? For example, if you use 4 different commercial probes, are the 4 probes reported separately with commas in between?
Hang on, I'm not sure. Can you say that question again?
I think that, okay, for the CLL example, how are the probe sets identified and separated? For the example, you use 4 different commercial probes. Are the 4 probes reported separately with commas in between? I think it's
probe kit. The probe kit, that particular probe, it would obviously things will depend on which manufacturer you're using because they do vary how they mix them together. But the probe set we're talking about there has one hybridization which does TP53 and ATM, and the other one does the centromere of 12 and the 2 probes for 13, and they've got different fluorochromes, and you do them as 2 separate hybridizations.
Perfect. The other ones are I think there might have been a misstep on one of the questions in the poll questions. There was a question about 2 people asked, there's no comma in between the sex chromosomes and -7. I think it was one of the middle questions.
And I just want to say that I did answer a couple of questions. I typed answers, so they're in the answered sections of the Q&A.
I'm just looking at the -7 on mine. Oh, there is a comma missing. They're quite right. There's a comma missing.
Good job, guys. And then we'll end with this one. For the 821, why was the 21Q22 at the 400 band level and the 21Q21.3 at the 700 band level?
It depends whether or not that was according to what resolution you see on your G banding. So if, for instance, you are lucky enough to have really nice preps on a neoplasia, and to be perfectly honest, it's rare, and you got it at that level and you could see the abnormality, then you could change your breakpoints. But most of the time you're dealing at 400 base pairs per haploid set, and they're the breakpoints you'd use. It's just used as an example of how you would change it if you had a higher resolution.
And thank you so much. And I will do a quick exit and give everybody the PACE scores or PACE code. So again, reminder, there's a third ISCN updates on May 20th for optical genome mapping. So that'll be very interesting. And this one will include both Ross and Jean again. The reminder that the annual meeting, early registration ends on May 21st. It's between August 3rd and the 6th in Houston, Texas. And I hope to see everyone there.